All right, why don't we go ahead and get started? People are still logging in, but I know we have two presentations today, Moritz and Rachel. So does anybody have any quick announcements or news that they want to share before we get started? Papers, grants, anything along those lines?
I have a quick announcement. Folks should see on their calendar that our next WIP is going to be next week, not 2 weeks from now because of Foley. So we'll reconvene a week from today. And also just wanted to congratulate Claire publicly on her promotion to associate professor.
Woohoo! Congratulations. And the thanks she got is she's submitting an R01. The due any day now, actually almost pretty much at the finish line. So
as am I.
That'll deserve a congratulations too.
I will also be going out on maternity leave very soon. I realize one of the awkwardnesses with Zoom is that if someone's very pregnant, you may not know that even if you interact with them regularly. But in case anyone did not know, I will be on maternity leave starting the end of October through sometime in January.
Great, thank you. All right, just also want to make sure that we've welcomed anyone new. Catherine, I don't know if you've had the chance to introduce yourself to the group. Do you want to just say a quick hello if you haven't?
Yeah, of course. Hi, everyone. I'm Catherine. I started fairly recently, like this past summer. I'm a new data analyst. I actually graduated from Sinai in June with my master's in biostatistics. So I'm definitely very fresh and eager and trying to get oriented still. But it's been great so far. I've been working with Catherine Ornstein, some of you may know, and it's been great. It's really great to be part of the team and formally meet everyone.
Great. Thank you, Catherine. We're happy to have you.
And Catherine works really closely with Beyond Lou, who many of you have met as well.
All right, why don't we go ahead and get started? Do we know who is going first?
Moritz will go first.
Okay, great. Why don't you can go ahead and get started. Maybe we can. Great. All right, we can see that.
You see my slides and you can hear me?
Yeah.
Perfect. Great. Thank you so much for this great opportunity to present my work in progress to this amazing group. I'm Moritz. I'm a visiting physician researcher from Berlin, Germany. I graduated medical school last year in Germany, and my plan is to train in cardiology and advanced heart failure and dedicate my career to improving access to palliative care for patients with heart disease. I previously worked in heart failure research in Berlin and at the Center for Interventional Cardiovascular Research at Mount Sinai Heart. But now I'm working with you guys at the Department of Geriatrics and Palliative Care. I'm working with Laura Gelfman to learn more about palliative care research and study the advanced heart failure population from a palliative care point of view. This project, however, is dealing with the palliative care population overall, and it's called Leveraging Functional Status Measures to Guide Palliative Care Delivery. And first of all, I want to acknowledge all the people who contributed to it and who support me in general. That's first and foremost Laura, of course. She got me here and she made this all possible. And she's dedicating countless hours of her time to supervising me. And yeah, she's giving me this incredible opportunity to learn and grow as a researcher. Big thanks also to Li Zeng, who's running all the data for this analysis, and to just an amazing team of people I work with, collaborators, people who support me and who have provided input in this analysis. And very importantly, I want to acknowledge all the clinical palliative care teams at Mount Sinai who do the day-to-day groundwork and collected the data we are analyzing here. This is still very much work in progress, and we would love to have your thoughts and comments on this project. The overarching questions we would like you to bear in mind are, clinically, how do you make sense of our findings, and how do you think they could inform your clinical practice, if at all? And what comments do you have on our methodological approach, and how could we refine it? A few words on the rationale behind this project. This is a slide by Kamel and colleagues who did some projection for the future of palliative care. In the gray, the lighter gray shade, we see the amount of patients who are eligible for palliative care, and this is projected to increase substantially over the next decades. The palliative care workforce, however, in dark gray, is projected to stagnate rather. So in order to address this mismatch, we need simple and clever tools to help us do the job, to allocate the limited resources we have in a targeted way. As Laura always puts it, to deliver the right resources to the right patient at the right time. One such tool that might help us do this job is the Karnofsky Performance Status. The Karnofsky Performance Status, or KPS, quantifies functional status on a scale from 0 to 100. It was introduced in the 40s to quantify response to chemotherapy, and it has been used in a variety of different clinical settings to guide therapeutic decisions. The Australian modified version of the KPS, the AKPS, contains a tiny modification of wording to accommodate care delivery in both in- and outpatient settings. And in this presentation, I might be using KPS and AKPS a little interchangeably. The classification works based on very simple questions. First of all, you ask yourself if a patient is able to carry out normal activity. If yes, the KPS is greater than 70, and depending on the degree of symptoms, it's 80, 90, or 100. If they're not able to carry out normal activity, but are not bedridden most of their time, they will have a KPS of 50 to 70, depending on the assistance they need with their activities of daily living. And if they're bedridden more than 50% of the time, they will have a KPS of 40 or lower. And the KPS correlates well with other measures you might be familiar with, such as the Palliative Performance Scale or the ECOG Performance Status. So in this study, we sought to investigate how the KPS can discern palliative care patients with different clinical profiles, and how this can in turn inform the delivery of palliative care in the future. This is what we did. This was a retrospective evaluation of data from the Inpatient Palliative Care Consult Registry. This registry aims to capture all patients who received an inpatient palliative care consultation across all sites of the Mount Sinai Health System. And clinicians fill out the inpatient palliative care consult template for patients in Epic. So data for this registry is pulled from two sources. The first one is the MSHS-PC EMR database that pulls data from Epic, readily available patient variables like demographics, admission and discharge dates, but also variables collected during palliative care consultation and entered into Epic. This includes the KPS, a comprehensive symptom assessment, the ESAS, Edmonton Symptom Assessment Scale, the reasons for palliative care consults, the capacity to designate surrogate decision makers, and other variables. And this Epic part of the data is linked with MSX administrative data to obtain diagnostic codes and the discharge disposition. So we retrospectively evaluated data from this registry. We included patients who received an initial palliative care consultation and were discharged between 2020 and 2021 across 5 different sites of the Mount Sinai Health System. And we excluded patients with missing key clinical information and patients with a KPS of 0. And we ended up with roughly 6,000 eligible patients. To assess if the KPS can discern different clinical profiles, we stratified our population into 4 subgroups based on the KPS, and you can see the subgroups here. They correspond with the ECOG, and we chose them because they represent clinically meaningful categories. So patients with a KPS of greater than 70 have no difficulties with their ADL at all. Patients with a KPS of 50 to 60 have difficulties, but are not bedridden most of their time. Patients with a KPS of 30 to 40 are bedridden most of their time. And patients with a KPS of 10 to 20 are completely disabled and dependent on extensive nursing. So this was our study population. 6,000 patients, more or less, mean age of 70 years, 50% identifying as male. And the mean KPS was 33, median 30. So on average, pretty poor functional status. We classified patients according to Amy Kelly's serious illness groups in order to understand what the underlying condition, qualifying them for palliative care, what that condition is. We modified the Amy Kelly's definition slightly, though, to also include sepsis and COVID-19, because we found those were highly prevalent in our population, and we only used ICD-10 codes to make this classification. Now, if we look at our population stratified for the Karnofsky performance status, we see that, first of all, patients with lower functional status on the left are older than patients with preserved functional status. No differences with regards to gender, but we see that the makeup in terms of serious illness groups vary significantly. So the patients with the poorest functional status, only 12% of those were cancer patients. Patients with the highest functional status, half of them were cancer patients. So we decided to look closer into the KPS makeup of the different serious illness groups. And that's what you can see here. So the graph represents the KPS profile at the time of palliative care consult, divided by the different serious illness groups. On the very left side, we see cancer patients. And here we see that almost 50% of patients are yellow or green. So almost 50% of patients have a KPS greater than 50. If we switch over to the very right side, we see that for patients with neurological disease, less than 10% are yellow or green. So less than 10% have a KPS of greater than 50 at the time of palliative care consult. We have two interpretations for this that are kind of complementary. Of course, these differences might be reflections of the degree to which a condition is disabling patients. So for patients with neurological disease, they just might be severely disabled just by the nature of their condition. And that's why their functional status is so poor. But when we look at the patient with cancer, those, of course, can also be very disabled by their condition. But apparently, most of the patients with cancer still have a functional status greater than 50 at the time of consult. And of course, that might also just be a reflection of referral practices and referring patients earlier in the disease trajectory. So, in addition, this should caution us that the makeup of our KPS subgroups that we're looking at differ significantly with regards to the underlying condition. So this might confound our comparisons based on the KPS subgroups that we'll be making later, and we should bear this in mind when we compare the KPS subgroups in more detail now. This is a comparison of discharge disposition stratified for KPS at the time of palliative care consult. On the very right side, we see that patients with a KPS greater than 70 are most likely to be discharged home. That's illustrated in white. On the very left side, we see that patients with very poor functional status, the majority of those expires during hospitalization. And the percentage of patients discharged to a hospice facility or to home hospice, that's the darker two shades of gray, that's actually highest in patients with a KPS 30 to 40. This is, of course, kind of stating the obvious, that patients with poor functional status are more likely to die. But we believe that thinking about this at the time of palliative care consult and being aware of how this is kind of predictive of the discharge disposition might inform discharge planning and early identification of patients with special discharge needs. In the next step, we also compared the reason for palliative care consult between the patients in our different KPS subgroups. The primary reason was classified by the palliative care clinician who completed the consult. And on the right side of the panel, we see that in patients with the best functional status, the predominant reason for consult was management of physical symptoms. That's illustrated in pink. On the very left end of the spectrum, in patients with poor functional status, we see that goals of care discussions and advanced care planning and decision-making are the predominant reasons for palliative care consult. And in 10% also transfer to the palliative care unit is the reason for consult. So we see a gradual shift there. And we overlaid this bar chart with the proportion of patients who were deemed to have capacity to designate a healthcare proxy. That's the black line. We see that drops from 90 in patients with a high KPS to almost 10 in patients with the poorest KPS. So what we see here is that the need for clarifying goals and decision-making increases with worsening functional status. But paradoxically, the capacity to designate the decision maker and maybe even also the capacity to engage in meaningful serious illness conversation altogether decreases at the same time. In addition to this, we have two additional takeaways from this. First of all, different reasons for consults might reflect different palliative care needs, which the palliative care team is tasked with. And different team members of the multidisciplinary palliative care team might be best suitable to address those differing needs. So this might inform allocation of resources to some extent. In addition, we see here that needs regarding symptoms differ significantly between the different KPS subgroups. So symptoms are apparently the largest issue in patients with a KPS of greater than 70. So we decided to look deeper into the association of KPS at the time of palliative care consult and symptoms. We use data from the Edmonton Symptom Assessment Scale here. That's the main figure. Here we see the relationship of KPS and symptom severity and prevalence for 10 different symptoms. So it's 10 mini panels, basically. Each panel represents a different symptom. The height of the bar indicates symptom prevalence, and the color indicates symptom severity. And functional status increases from left to right in each panel. So if we zoom in on the very left, we see that prevalence and severity of inactivity is highest, so most severe and highest prevalence in patients with a KPS 10 to 20. And prevalence and severity they decrease in patients with higher functional status. So more severe patients in patients with more severe symptoms in patients with lower functional status. If we jump to the very right side of this graph and look at physical discomfort, we see that the prevalence and severity is highest in patients with the best functional status. And the severity and prevalence seems to decrease with worsening functional status. And if we look at those trends across symptoms overall, we kind of see two different clusters of symptoms. First, we see symptoms which are more prevalent and severe in patients with lower functional status. That's inactivity, anorexia, drowsiness, dyspnea, agitation. And on the other hand, we see symptoms which are more prevalent and severe in patients with higher functional status. That's nausea, depression, constipation, anxiety, and physical discomfort. We were not 100% sure what to make of this, and we were very worried about the serious illness groups confounding this. So the first thing we did was see if those trends that we found prevail if we restrict the analysis to just one serious illness group. And cancer being the most prevalent serious illness, we split it for cancer versus non-cancer. And this graph essentially shows that the trends we see are pretty much mirrored in patients with cancer versus patients with non-cancer. Of course, that's only one serious illness group, and we would like to account for more baseline variables. So we sought to model the severity of each single symptom based on KPS while adjusting for possible confounders. So this is the model we chose to represent this problem. On the right side, we see the dependent variable is symptom severity. That's an ordinal variable with 3 levels, so mild, moderate, severe. And the independent variable was, of course, KPS and baseline variables for adjustment. And there was one question we faced regarding how to deal with KPS, because even though it looks like a continuous scale from 0 to 100, KPS is actually a discrete scale. You can't have a KPS of 15. You can only have a KPS of 10 or 20. So it's actually an ordinal scale with 11 levels. But if we would input it into a prediction model like this, we would get many different coefficients, one for each level step. So instead, we decided to use KPS as a continuous scale from 0 to 100. We assumed that it's monotonic, which means that an increase from 10 to 20 is comparable to an increase from 80 to 90. And this allows us to get one single coefficient for each symptom. And that's what we see here. So on the left side, we see the association of KPS with symptom severity for each symptom. We see significant associations for all those symptoms. And we see one group of symptoms where the coefficient is negative, indicating a negative association, and another group where the coefficient is positive, indicating a positive association. Bear in mind that a positive association means when KPS is higher, symptoms are higher too, and when KPS decreases, symptom severity decreases too. On the right side, you see adjusted analyses, adjusted for comorbidities, age, gender, and the most prevalent serious illness groups, sepsis, cancer, and COVID. And we see that the results remain virtually unchanged after adjusting for baseline characteristics. Those are pretty much the results I wanted to share with you. Just to wrap it up, those are kind of our main findings. Functional status at the time of palliative care consult can identify palliative care patients with different profiles regarding discharge disposition, reason for palliative care consult, and symptom profiles. We have to keep in mind that KPS was at the time of consult, not at the time of admission, and it might have deteriorated during admission. And this is all clinician assessment. So this is not self-reported by patients. Also, symptom assessments are clinician assessments. That's a limitation here. And this was a retrospective analysis. So we have to bear that in mind. But that's pretty much all I wanted to present to you. And those are the questions we would like to have your feedback on. And we are very excited to hear what you have to say about this project.
Great, thank you. Maybe we could start, there was a question in the chat about whether the finding of KPS and symptom severity was surprising to you. From Claire.
I think so. I think my intuition was that as KPS worsens, symptoms get more severe. And this finding that we have symptoms that actually appear to be less of an issue in patients with functional status was definitely surprising at first. And we were really trying to wrap our head around explanations for that. And that's also what we would like to have your thoughts on.
And I think when we obviously think about it, it makes sense, right? Like you're not eating, like if you actually think about it, but we never looked at it in that way. And so it was sort of thinking about parsing out which symptoms get better, which get worse. I guess I there's not been anything sort of published at looking at sort of how that shifts over functional changes in terms of specific symptoms. But obviously there's a clinical story that you could tell why that is, right? If you're not moving, you're not as much pain. You're not eating, you're not as much, you don't have as much nausea. Like all those, it makes sense, and you can write a sort of story about why that is.
Yeah.
You might also try to, sorry,
Chris.
I was just going to say, you might try taking the people who are on ventilators out of the equation and have a look to see what it looks like, because I know as a clinician, when you're filling those out for someone who's completely nonverbal, it's sort of like, no, they're like all zero because they can't report any of them. So except for like inactivity and drowsiness. So you might try looking to test that to see if it's a confounder.
Yeah, I think the tricky thing is, speaking from the clinician side to all of this, is how the clinicians are using these measurements. First of all, KPS is interesting to me because I think I mess it up all the time on every patient I see, because I'm always confused about like, is it when I see them in the moment, or was it yesterday, or was it at the time of admission? So like there could be some variation there, but I will say anytime we're consulting in someone who's like imminently dying or in the neuro ICU with basically minimal brain function, I think many of us, as Laura well knows, people fill out the symptom assessments very differently. I think many of us are tempted to identify a symptom as like inactivity or loss of appetite in those cases. But like, is that actually symptom burden, or is that us just attempting to fill out the template to identify something for that symptom assessment? Or like, are they truly bothered by being inactive if they have no brain function in the neuro ICU? I don't know, but it doesn't surprise me out, because like those groups of consults of people who are essentially non-responsive, like you're gonna say the like inactivity, like fatigue, anorexia, or like dyspnea if it's really end of life and you're adjusting opioids for, tachypnea. So I guess that's what I would say of like to Chris' point about like, I don't know how you address that, because like some of it is people on vents, but some of it is just like the definition of who is a KPS of 10 and what symptom could they possibly have if they have a KPS of 10. I guess if they're restless, you could be seeing some pain. But like, is it a symptom, or is it just that that's the way we're filling out the template because we want to put something?
I guess it goes to how you define symptom, right? I mean, right, we certainly are not assessing if it's a bothersome symptom, right? That's but nor do I think we really could.
Yeah.
In that population.
Like, are you bothered by your fatigue if you're comatose is like a more philosophical question than I think any of us can answer.
Any other last thoughts? All right. One more thought in the chat that maybe you could just respond to in the chat about understanding KPS over time and how that works. All right, thank you so much. I think we will now move over to Rachel.
Hi, everyone. Can you hear me well?
We can hear you. Now we can see the slides in the right mode. So you're all set.
Okay, great. So my presentation is also long overdue due to many multiple delays. One of them is the inexperience that we had with Medicare data, ResDAC, CMS, all words that I've discovered in the last year and a half. And it's been a steep learning curve, but also an amazing learning experience. And I feel very empowered, or much more empowered than I was now, because of everything that seems available to our research group now. This is also overdue because I was supposed to present in March, and we finally received the data in February, and I gave birth end of February, a little earlier than I was supposed to. So I never got to present in March, but I'm very happy to present today. So I'll start with giving you a brief background on how a medical doctor such as me and an aging biologist and an aging biology lab got into epidemiology. Then I'll talk about a little bit of our hypothesis and what the pilot project that we got funding from the OAIC at Mount Sinai, the Pepper Center, and then a little bit about the proposal that we are resubmitting to GEMSTAR and that we'll be submitting for the first time to the TL1. This is in a few weeks. Okay. Oof. So there's no need to present to this group the challenges that we face today with the aging population and the growing number of patients with Alzheimer's disease and dementia in general. The problem as we see it in our lab is that there are currently no effective therapies for Alzheimer's disease or aging-related diseases in general. Drug development is expensive, and Alzheimer's disease in particular is considered high risk by pharmaceutical companies who have, for the most part, abandoned drug development for dementia after they have had so many failures. But we believe that these failures could be because most, if not all, drugs that are developed for Alzheimer's disease and those that are FDA approved today for dementia focus on one target, despite the fact that research has shown increasingly that Alzheimer's disease, dementia, and aging are complex conditions, and that they probably multiple mechanisms are involved. So we propose, instead of a target-based approach, which is the one that's classically done by pharmaceutical companies, to do a phenotypic approach. What this means is that instead of developing drugs for a target, we look at how drugs affect phenotype or affect the outcome, which is a readout of disease. So we've developed a high throughput drug discovery platform that I'll be presenting a little later. And our wish is to validate this in humans. The end goal is clinical trials, but the leap between model organisms and cells to humans is big. And so this is where we thought there was a great opportunity for epidemiology and pharmacoepidemiology. So just a small point on drug repurposing, as a lot of the drugs that we're screening and focusing on are drugs that are FDA approved, and drug repurposing is particularly interesting for older adults who are often excluded from clinical trials, as you know. And so with drug repurposing, there's already often real life data on side effects, and it's also less expensive and quicker to develop. And I've already mentioned, this is an urgent issue, and so the quicker you can develop drugs, the better. So our hypothesis is that drugs that are protective in our model organisms will reduce the risk of developing Alzheimer's disease in humans. So here's a figure of of our approach and what we've developed. So the lab has been working on questions of aging and biology of aging for many years now. And based on the acquired knowledge of biology of aging, based on results from GWAS, from disease expression profiles, and from our knowledge of model organisms, we were able to choose validated and relevant models for dementia. We're working on dementia mainly now, to screen the drugs for Alzheimer's disease. And so we've chosen two models, C. elegans, which is a worm, and it's a C. elegans, which is a strain specific to Alzheimer's because it accumulates A beta, which is the protein that you can find in brains of patients with Alzheimer's disease. So it accumulates A beta in its muscle wall, and with time it will develop paralysis. This happens with time, it develops paralysis. And so the more effective a drug will be, the less paralyzed the worm will be. Another model that we're using is microglial cells. They've been implicated in Alzheimer's disease by GWAS, and the more efficient our drugs will be, or the compound or the intervention that we do, the less inflammation there will be, and in particular the drugs will be able to inhibit TNF-alpha and IL-6. So from there we have two approaches. One of them is thanks to the Pepper Center to validate the results with a pharmacoepidemiological approach. And the other is that we explore the results of the best drugs that we found, the classes of drugs that we found to be protective in our models with bioinformatic tools to develop novel compounds and to maybe understand the mechanisms behind the protective effects that we saw. So we've actually developed novel compounds. One of them is patented, and we're working now on validating it in vitro and in vivo. But that's not what I'm going to present. I'm going to now present the pharmacoepidemiological work. So this is just the result from one of the screens that we've done. We screened over 3,000 drugs in total. As you can see on the left, there's the drugs the best drugs in our from that screen, and the second column is how effective the drug is. So the higher percentage of healthy worms, the less paralyzed they are, and the better the drug works. So the top drug here is phenylbutyric acid, which is actually right now in clinical trials. And so for the Pepper Center project, we chose to assess whether phenothiazines, which was the class of the drugs of the third best drug in our list, whether that class of drug was protective. So this brings us to the pilot project. For which we got funding from the Pepper Center. And so I really want to say again how extremely grateful for the funding we obtained we are, and for this amazing opportunity because we are complete novices in epidemiology, and I'm not sure anyone or anywhere would have trusted us enough to let us do this. And this is really a direction that's a huge step forward for our lab, and for me in particular. And so this is the funding we got. The goal was to assess if phenothiazines were protective in Alzheimer's disease using Medicare data. It's mainly a feasibility study, and we're using this experience to apply for federal funding. So we applied and we obtained 1 year of data from 2019 from Medicare. We have a random sample of 1 million beneficiaries, and we really wanted to make sure we weren't missing any Alzheimer's patients. So we really ordered as many files as we could. So we have MedPAR outpatient hospice files and the Part D event files because we're interested in the drugs. It's a cross-sectional study, so it's really just a snapshot. So we're really mostly doing a descriptive analysis. We're looking at patients exposed to phenothiazines versus not exposed, and seeing if these patients are different in terms of aging phenotypes. So for the preliminary findings, first, I was surprised because I've heard a lot of negative comments on Medicare data, but we found it to be accessible and good quality. One thing that did surprise me as well is that 3% of the beneficiaries from the data set did not receive care in 2019, and I was not aware of this. I mean, I hadn't read this in articles, and so maybe you have ideas on this, maybe this is normal. Our goal in terms of feasibility with this pilot project was to assess whether our power calculations were correct, and to make sure that what I had seen in publicly available and free data sets that you can have on ResDac and CMS for Medicare was correct and applicable for our drugs, and if it would allow us to find something. And so our calculations were correct. So we needed at least 100 beneficiaries taking phenothiazines to be able to have significant results. And so this is what we found. So different criteria are possible to assess exposure to the drugs. And I proposed in the pilot project accumulated dose calculation, but after discussion with the real pharmacoepidemiologists here at Sinai, they suggested to select beneficiaries who have at least 2 prescriptions of a drug. And so if a patient goes back to take a drug, he's considered to have to take it regularly. A negative surprise is that we only found 5% of beneficiaries that in our data set that have dementia. I'm not sure why this is. The understood or recognized percentage of beneficiaries with dementia is 10%. And I have the list of codes if someone that we used, if someone has an idea. We still have to check if our sample is younger than the whole sample or the whole population. We still have things to check for this. So this is just general information on the data sets that we have. For example, there's approximately 15% of all patients were hospitalized, and almost all patients, all beneficiaries had a prescription in 2019, the year that we have data for. So here are demographic characteristics from our data set. So, I mean, what we can see is that the mean age is 75 years old. Patients or people taking phenothiazines seem younger, 73 years old, and are more male. 60% take phenothiazines versus the control, which are 40%. And I've told you about the issue of 5% of patients with dementia. We still have to check and continue assessing the data. This is the very beginning of our statistical analysis, and it's the opposite of what we would like to see, since here it shows that patients taking chlorpromazine, which is our best phenothiazine, have a higher risk of having Alzheimer's disease. But I have to say this doesn't make sense to the clinician in me. So patients taking chlorpromazine have the odds of having Alzheimer's disease is 3.9. So, and this is significant. Now I want to talk about the future proposal that we will be submitting soon. So this is a resubmission. The goal is to expand on the first results that we obtained in the pilot that I just presented. We'll be expanding with a longitudinal follow-up, and we would like to have data for 5 years, 5 consecutive years. We can't really afford more with GemStar, and we also want to look at more drugs. So we'll be looking at the 50 best drugs that we have results for, and focusing on the drugs in the order of efficacy in our models. So as I told you, the top drug is phenylbutyrate acid. That one's already in trials. So we'll be looking at them one after the other in order of most efficient to least efficient. As I said, it'll be based on the drugs. The choice of drugs is based on results of the 2 phenotypic screens that we've done. We've screened 2 libraries. The first aim is that we propose is to assess if FDA approved drugs from our first library, which we've shown to be protective in Alzheimer's models of Alzheimer's disease, reduce the risk of developing Alzheimer's in humans using the Medicare data. And our second aim will be to assess if FDA approved drugs from the second library that we screened. The second library is specific to drugs that have that extend lifespan. I want to see if these drugs that extend lifespan are protective of Alzheimer's in humans. There is a subtlety here between health span and lifespan, and the R01 that's actually funding our lab right now, the results have shown that, so the proposal was to show that drugs that extend lifespan also delay aging-related diseases, and we've shown that actually this isn't always the case. So we want to also look at that subtlety with the data here. As I've said, this is a resubmission. So we've had, so we're answering critiques. Most of the critiques were on our approach and methods, and we've now made modifications accordingly. They critiqued the lack of expertise, and so we're very thankful to be able to add mentors to the mentoring team. Dr. Aldridge, thank you for being the Medicare specialist in the team. We also have Sven Sanden, who's a biostatistician who's worked on pharmacoepidemiology, who will be joining us. And one of my mentors, Avi Reichenberg, just obtained an R01 for a pharmacoepidemiological project, which is pretty similar to this one, and which is looking at the drugs that affect autism. we also had, so we had also, and of course, I am now a much better expert than I was 2 years ago with epidemiology. We also had comments on the fact that we weren't really taking into account time varying exposure. So instead of a logistic regression, we're now doing a Cox regression. We also got criticism on sensitivity analysis. And so the main challenge here is confounding by indication. We hadn't really wanted to do this because we're looking for a positive correlation. So in theory, the drugs that if a drug works, it's protective. And so it would, for example, if we have an epileptic drug, it would be a little counterintuitive to think that epilepsy is actually protective for dementia. But we will now do a sensitivity analysis and focusing on confounding by indication, whether by disease or target. So target would be if a drug works, we know that it targets a certain receptor. We'll check all drugs that target that receptor to make sure that the drug itself is what's protective. I think that's it. And so I really wanted to acknowledge people who've helped me come this far and who have supported an aging biologist going into epidemiology, especially Dr. Mobbs. Thank you so much, because you're not an epidemiologist, but you've really been very open-minded and letting me try and to do this project. And then of course, all the other mentors involved in the project, and Melissa Aldridge for, helping us get this funding. And Caitlin, I've been harassing her with emails for the past 2 years. So thank you very much for your patience. And then of course, the whole lab and the NIH for the funding. I don't know if anyone has comments on what we found or. I know this is not the typical approach that people in this WIP usually have, but yeah, it's very exciting for me as a clinician, and I love attending the WIPs because it's much more clinical than what I'm doing in the lab. But yeah, I like the idea of being able to bridge both worlds.
Thank you so much, Rachel, and thank you, Charles, for being here as well. So what people are thinking, because we would like to get some other perspectives here, particularly people who have experience with Medicare data and identifying these, but can you explain again, it seemed like the first, when you did your pilot, it was just a cross-sectional look at the two. Can you explain in the follow-on what the design looks like how, when you identify each, and is it now longitudinal for a certain number of years?
Yeah, I didn't go into too much detail because I was worried about time. But so so this was a cross-sectional study, the pilot. So we really included everyone. Now we'll be following beneficiaries up for 5 years, and we'll be excluding beneficiaries who have Alzheimer's disease. So we'll be looking at whether people who are taking drugs are protected of having dementia. So I don't know if that's answering the question, but
so no dementia to start, and then a
yeah.
5-year follow-up identifying new incidents of dementia based on whether or not they take the certain drugs.
Yeah, ideally we'd have 10 or 20 years of data, but yeah, we're going to start with 5.
Okay.
As a side project, I mean, we'll be looking at other, so the proposal for GEMSTAR is really only for dementia, but I'm also hoping to look at other conditions related to aging. So, elements of frailty, etc.
Rachel, I know one of your questions was on the identification of people with dementia and why your proportion is lower. Do you mind going back to that slide where you talk about your method for that and the data you used?
Yeah, wait, let me share again. So I'm not sure that particular slide has much information, but wait.
The one that showed the files.
Oh,
that you-
yeah. So the files, yeah, the files are, it's this one, and I can show you the codes, but yeah, we try to be as broad as possible.
And this was fee for service. Yeah, I guess, oops.
Yes, it's fee for service.
Yeah, I wonder the things that I see that could potentially be gaps in terms of where the codes often come from are, I see outpatient, is that institutional outpatient? Or does that include the carrier file? And I can explain to the group, I know that's like a real nitpicky question.
So that's a good question. It's part, yeah, I mean, the way it came to us is part B, outpatient. So I mean, it's a huge file, so I was assuming that, and the percentage of patients that are in it, wait, how am I gonna get back?
We can talk offline, but just for everyone else, outpatient data in Medicare is super confusing because if you have an outpatient service and it's by a provider who also has a billing center that bills inpatient. So like, let's say you go to the geriatrics clinic at Mount Sinai and it's the same billing center as Mount Sinai. So they're also billing inpatient, that you fill out a certain billing form. And then it shows up in what's called the outpatient file or the outpatient institutional file. If, however, your billing is structured as a freestanding outpatient clinic, then you would fill out a different billing form, and that shows up in the carrier file in terms of Medicare data. So just that would be one thing to look into of like making sure you have that, because my understanding is most of the claims-based dementia diagnosis are found in the outpatient broad, like using that non-specifically files. It is interesting too, it looks like you have MedPAR, but not the inpatient file. And then health would be the other place that you might see some diagnoses.
So yeah, we chose to have MedPAR and not inpatient or Part A, following many discussions that I had with people at ResDac. They're amazing actually, and they actually checked whether the beneficiaries would be different, or if we'd be missing claims if we were taking MedPAR instead of Part A, and we were missing like 0.001% of claims. So it was like so insignificant that it was really worth it, worth taking MedPAR. But that was something I was worried about when we made the choice, but they basically convinced me that it wasn't going to be an issue.
Well, if you want to connect and actually just like cross-check your codes and things like that, we can definitely connect you to people on our team that can just go through it and see if there's any gaps to get that percent up.
Yeah, I'm happy to take a look at it. And there are also a few other alternative algorithms for dementia diagnosis that have been published in the last year. So we can talk about that.
Yeah. One of the things we haven't had time to look at now but we want to look at the drugs for dementia and see if that includes more patients. Yeah. We haven't had time.
Yeah.
Life is too short when you have too many children.
What is your resubmission timeline? Is it that for this month?
Yes. It's really soon.
Well, we can, I mean, at a minimum, you could kind of acknowledge, you know, towards the end of the grant that you realize there are some new algorithms and that like our team here with a dementia focused PO1 is exploring them and just reference it. So you can highlight that, they exist, and you'll do a little bit more with that, if funded.
Yeah, thank you. I mean, I think the proposal is definitely stronger than it was last year, because we do have, even though it's not a lot, we do have some pilot data, and we can prove that we know how to open the files and we know how to look at them. And we have people we can talk to that know the files in pharmacoepidemiology. So actually it's very, I mean, I feel more confident than I did last year.
Good.
Yeah, getting through the ResDac process is a thing. So congrats.
It really is, but yeah, now I mean the people are very nice. I have to say it's been only a great experience. I'm only sorry that I wasn't able to present earlier.
So I'm wondering, actually, are there any sort of you mentioned a little bit about that in terms of the drug targets or screening, looking at different medications. So really thinking about whether there are more sort of common medications that fits the bill from the biological model that would be treating more common conditions that may actually not be really pertaining to, antipsychotics and other medications that would really may have both confounding it by indication also, and also in terms of, the linkage between these psychiatric illnesses with a later on development of cognitive impairment, or however Alzheimer's disease is diagnosed, is a little bit tricky to do. So just wondering in terms of the expansion of different sort of medication targets that may actually be able to have a really a potentially a larger sample size that you can look at and whatnot.
I mean, obviously, phenothiazines was a tricky class to start with. It really is our third best class, and it's the class that we use to develop the novel compounds because it just works so well. And we actually have many reasons to think that it could be protective. But of course, in our data set, for example, 1 year of data, patients with Alzheimer's are actually probably, at higher risk of getting phenothiazines because they have these psychotic episodes and, just to calm them down, unfortunately. And so our results are not surprising. And that's what I said. The main goal, I think, with this pilot project was really to discover the world of epidemiology. And we have other classes of drugs which are more commonly prescribed, which we know to be effective in our models. And there's actually another group that published a year ago a study that's not similar because they didn't start with a phenotypic study, but they started with bioinformatic work, and then they assessed the results from their bioinformatics work in Medicare data, and they found one of the antihypertensive to be protective against dementia. I mean, so definitely we'll be checking the 50 best drugs, and some of them are more commonly prescribed. But I have to say phenothiazine is also a really interesting class for us. So we'll be checking it again with more data. But there are many confounders for it. Many. We only looked at chlorpromazine for now, but actually in that same class, there are, tricyclic antidepressants, which people can get for long periods of time without having dementia. So we haven't had time to look at those yet, but we will be.
Great. Thank you so much, Rachel. This is such an exciting area. I'm thrilled you're doing it. It's fascinating. I understand like a sliver of it. But I get the big picture, and I love that you're exploring that. So good luck, and please let us know how we can help, and certainly we can do that cross connection. There's one other note in the chat from Mohammed if you want to take a quick peek, but it's 1 o'clock, so we'll sign off. Thank you everyone for participating, and we'll see you next week. All right, bye.